And I just want to let the audience know that we'll be starting in about 30 seconds, and just want to let everybody come in and take their places. All right, I'm going to go ahead and get started. I'd like to say good morning and welcome to the Arizona Capital Times Morning Scoop. I'm Gary Grotto. I'm your host for the next hour, and I'm the executive editor of the Arizona Capital Times. And today we're going to discuss what Arizona State University and the Arizona Board of Regents are doing to address the state's shortage of healthcare workers and boost the state's health system performance. Now, before we get into the nitty-gritty of what you're going to learn is a very innovative solution, I'd like to thank our sponsor, Arizona State University. ASU is consistently ranked #1 in the United States for innovation, and you're going to hear a little bit about that innovation today. And it has an enrollment of 82,000 students, 4 campuses in the Phoenix metro area and 1 in Lake Havasu City. ASU, through its charter, has advanced a new model for the American Research University called the New American University, an institution committed to excellence, access, and impact. And now I'd like to introduce our panelists, first of which is Dr. Michael Crow, president of Arizona State University. President Crow has led the university since 2002, and he spearheaded ASU's rapid and groundbreaking transformative evolution into one of the world's best public research universities. Good morning, Dr. Crow.
Morning, Gary. Nice to see you again.
And joining President Crow is Fred Duvall. Fred is chair of the Arizona Board of Regents. He's an ex officio member of the University Governance and Operations Committee, Strategic Initiatives and Planning Committee, and Audit and Risk Management Committee. Regent Duvall previously served on the board from 2006 to 2012 when he was appointed by Governor Janet Napolitano. He's the first regent appointed by a governor of both parties. Good morning, Regent Duvall.
Good morning, Gary.
So before we begin, I'd like to let our audience know that we will have the chat on, and please use it. Feel free to send questions our way. And but just be reminded that it is just for questions, and don't use it to criticize our panelists. Go on to other subjects. Stay on subject, and don't talk amongst yourselves. If you could refrain from that, we'd appreciate it. So thank you very much. Now we're going to talk about a medical school that is not your father's medical school. If you remember the old commercial from Oldsmobile. But there was a need behind this. And, ASU, from what I understand, at one time, they did not want ASU to have a medical school. So what's going on? Can you tell us all about that, Fred?
Well, sure. Let me start. I chuckle when you say this isn't my father's medical school, because in fact, the U of A's is my father's medical school.
Okay.
My dad was the founding dean of the existing College of Medicine in Tucson, so I come at this with some family legacy. Gary, if I can, I'd like to take a minute and sort of set up the ASU conversation, because there's a broader context for it that's important. I think most Arizonans have had the experience I've had. Hard to see a doctor. Waiting times are really getting high. And, we're in the business not just of educating our students, but of trying to meet the workforce needs for the state of Arizona. And these wait times have many manifestations. I mean, can't see a doctor, hurts productivity. Obviously, it hurts quality of life. And it sends too much care to the emergency room, which is the most expensive place where you can get care. So we started looking at the data. And sure enough, Arizona, when we started the medical school in Tucson in 1967, brought Arizona up towards the national average in the number of physicians per citizens. We've now fallen back to about 47. 1 in 3 Arizonans don't have access to easy access to primary care. 1 in 3 hospitals have a critical workforce shortage. And so we're seeing these stresses, and it takes a long time to build a medical school. So the regents, in meeting with the president, said, look, we need to get after this because we've got to get ahead of it. And how do we marry the DNA of each of our schools with the state's needs? And the state's needs are more doctors and to drive the bioscience, life sciences agenda, which is becoming so exciting in Arizona's economic development plan. And so we've asked each of the three universities to each significantly increase their productivity of workforce in both the physician and nursing and allied health space. And what you'll see in this proposal is that while the U of A has been asked to increase its production of physicians out of its existing colleges, NAU has been given the assignment to focus on tribal health and rural health because that's sort of part of its DNA. And then I guess by way of getting to your question and over to Michael, the ASU highly innovative idea comes very much out of their DNA with the nation's biggest engineering school. So that's the broader context of how we're trying to meet the state's needs and do so consistent with sort of the pre-existing design strength and DNAs of each of the universities. And so what Michael has brought to us is very much consistent with what ASU is about.
Thank you. President
Yeah.
Crowe?
Yeah, so what I would add is that the regents have been very generous in their leadership and guidance of ASU, allowing us over the last 20 plus years to become this high-speed, highly innovative, scale, technologically enhanced university. And then I think the regents and the political leadership in the state and the general leadership in the state has seen the value of that, the effectiveness of that, the economic development impact that we've had, the kinds of things that we've been able to do in terms of enhancing educational outcomes, all those kinds of things at all levels of the state. And so when the regents come to us and say, we need more troops on the front line here of health outcomes for Arizona. One part of that is producing more doctors, which we will certainly do. But it's also, in general, we believe that we don't need the same of the same of the same. So we need to have a generational leap. So what we've decided to do is to launch a thing that we call ASU Health. And in it will be this new advanced medical engineering school. In it will be an advanced school of public health technology. In it will be a range of other kinds of programs, as well as, oh, by the way, let's produce 3 times as many nurses and so forth and so on, all of which we now have the means to do because of our changed faculty culture, the charter that you can see behind me, where we're focusing on, providing or taking responsibility for healthcare outcomes. And what I mean by that is, yes, we need more doctors, but we need doctors who are literally at the state of the art. They have every tool, every device. Imagine doctors who are not able to see 50 patients a week, but maybe they're able to deal with 5,000 patients with a node or a network in the way that they're trained and the way that they're interacting with data sets and computation and artificial intelligence. And even just yesterday, I have this little dot on my nose. I got to figure out what it is. So I'm able to send my picture to my doctor. The doctor then is able to send it to specialists. The specialists are able to do something. But even that is a crude thing. How do you make that so that healthcare, doctors' care, medical input, medical intervention, health outcomes can be ubiquitous from home, from work, from vacation, from this, from that, tools, devices, images, analytics, genetic therapies that are uniquely positioned to you specifically because of your specific genetic makeup as an individual. And so what we're building is a medical school, and in some ways I appreciate very much the regent's wisdom in having us wait until we were ready to do this. 10 years ago, we couldn't have done this in this way because we didn't know what we know now about advanced learning and advanced engineering and computation and artificial intelligence and augmented support systems for decisions and so forth. So we're going to be launching a state-of-the-art sort of mid-21st century, late 21st century medical school, medical engineering school, and we're very excited to get this going.
So medical engineering school. So the student that's going to graduate from there is going to 4 years of medical school and 4-year engineering degree. Am I right?
No, actually, we're designing it in a way where you can come in with a solid undergraduate degree, and you'll graduate from our medical school with an MD degree and a master's in engineering.
Okay.
And the most that we would need to get you up to speed to be able to do that would be one focused year. But we think that we have really advanced teaching technologies, learning systems, learning tools, visualization tools, all kinds of things. We think that we can produce with the right students these very advanced medical engineers who could work everywhere from a internist to a general practitioner to an advanced AI enhanced medical decision maker. Really, all those things we're looking to do.
Well, and that's what I've always been, when I first heard about this, and read about it, and I've tried to picture, you know, how it's going to apply to the consumer. Like you said, you had a little something on your nose, so you sent it in.
Still there.
I'm gonna go. I gotta go see my guy in a couple of weeks. In 10, 15 years, am I going to?
Well, let's just take the thing on my nose. So I've had some basal cancers on my nose. There's a chance that this is that again. What I want to be able to do in the future is send that in and have it not just viewed by a dermatologist, but by a computationally enhanced dermatologist who has an understanding of my genetic background, my previous treatments, my particular skin conditions. I want computational assistance for that doctor. And I just don't want somebody to say, yes, you should come in. I want someone to say, here's what we're going to do. I mean, I want a decision. And so what we have is what we're trying to do is to find a way where medicine can be projected to the person with physicians that are empowered technologically. Physicians are very smart and very intelligent and very capable people right now, but we want to take it 2, 3, 4 steps further along so that every interaction, everything that I'm doing, everything is a part of then the decision making. And that's what we want these new doctors to be able to do.
And Gary, if I can add to that point and understand how powerful this is in terms of all of the spin-offs. I mean, this is also about creating, clusters in the life sciences spaces and new technologies and new breakthroughs and new capital formation and new jobs and new businesses all around both treating better care for our patients and creating, the kind of ecosystem that is self-sustaining, that both creates higher paying jobs and creates more healthcare capacity in the state.
Okay. So you're also going to be involving, I forget the term you use, but you're going to be creating clinical engineers. What's a clinical engineer?
Well, the way to look at this is, so imagine now you're going to go see your doctor. Your doctor's going to look up your medical record. Your doctor's going to read that record. A clinical engineer in the future is going to be talking to a computer and talking to you, and it's going to be blended together in a way where your medical history, your medical model, what you need to stay healthy, to keep being there for your family and keep supporting your kids, or keep becoming a burden to your kids as you get older. The clinical engineer is capable of designing, building, operating, running, and optimizing all of these systems in ways that we have little glimpses of it now, but we're not producing enough people within the system here in Arizona to build these kinds of systems that enhance healthcare outcomes, make them more accurate, make them more safe, lower the cost. Let's just look at accidental deaths from medical care are still substantial in the United States. Well, how do you reduce that down to almost nothing? How do you develop new clinical systems, new clinical engineering outcomes that allow every patient to get the care that they need when they need it from wherever they are?
So, the student, I mean, you mentioned earlier that, MDs are very capable, very intelligent people. It seems to me that the student that's going to come to this medical school is even going to be, I guess, more advanced. How are you going to
more advanced? We've been using this joke lately that if you watch Star Trek, this will be the medical school that Leonard McCoy graduates from, who became the main doctor in the original Star Trek. And so that people have got to find a way. So it's not about everybody that's just a super geek will get into this medical school. It's about people who think about things in a broader concept. So we want them to understand computation. We want them to understand everything there is about medicine. We want them to understand what there is to understand about genetics. We want them to understand about innovation and humanities and human interactions and so forth. So we're going to be changing, advancing, and accelerating the curriculum. We're going to be using computational devices to enhance and speed learning, all these things. So what we need is, we don't just need more soldiers to enhance healthcare outcomes. We need more types of people in the health ecosystem of Arizona to produce better outcomes.
And more scale per
For
person.
scale, yes, which only technology can give you more scale.
Yeah.
You can't produce enough doctors to have one doctor for every 10 people, but you could produce a system which would allow people to have very close in, low cost, very effective healthcare from nurse practitioners and physicians managing these technology environments in which they're sitting. And then you save the face-to-face interaction with the face-to-face doctor for those things that are dependent upon that interaction.
Okay. And so where are we in the process of getting this school built, getting students into seats?
Well, as Fred said, the board has now given us the authority for the first time in the history of the institution. And it'll take 3 years to achieve accreditation. That's how long the process starts or takes. And then so we're looking at 3 years out to launch, and then 4 more years to produce the first graduates. Now, the good thing about that is that gives us an immense amount of time to build this absolutely unbelievably technologically enhanced medical school, which is what we're in the process of doing. We've hired a great team of individuals who are helping us to design that. We're finding the leadership. We already have what will end up being more than 70% of the faculty already on our faculty. We already have the scientists, the engineers, the humanists, the designers, the augmented intelligence specialists. We have all that. Now we want to add to them clinicians, advanced clinicians, all of the people in the medical arts. So it's about 3 years to get the thing going.
Okay. So there's other parts of this initiative. The other one was to expand the College of Nursing and Health Innovations. So can you talk about that a little bit?
Yes, so we're producing, and the wisdom of the regents was to ask us to produce not just, and Fred can comment on this, but not just a medical school. Most places just launch a medical school and add it to their institution. We're taking the entirety of ASU, 6,000 faculty members, 25,000 support staff, 80,000 students here on campus with us, every technology tool imaginable. And then we say to our nursing college called the Edson College for Nursing and Health Innovation, we want to go up from 1,400 nurses a year to 4,200 nurses a year, which is a huge chunk of the need for more nurses. We want to produce more BSN, Bachelor's in Nursing Science, more MSN, or Masters of Nursing Science, and then more nurse practitioners who are the nurses that can practice medicine and practice healthcare delivery on their own. We're going to be advancing the production of all of those as a piece of what we're doing, which again can only be done through these advanced teaching and learning techniques that we have really developed here at ASU.
And Gary, since President asked me to come, let me just add this. The other thing that I really like about what ASU is doing is that there's a component of this which is really focused on the study of the future of healthcare and well-being. And it is so important that we sort of recognize, obviously, given the pace with which change is hitting us, technology is hitting us, we will be getting our care in so many different ways that we aren't even envisioning. And so, back to your opening line, but producing more of my father's medical school type graduates will not meet the needs at the scale, the quality, or the techniques of the way in which we provide healthcare in the 21st century. So this is sort of both about inventing the newest, most forward-looking medical school and looking beyond it to how medical practice is going to change in the next 20, 40, 50 years.
And what's the Board of Regents' involvement going to be going forward as well?
Well, goal one was the green light. This is sort of an institutional commitment. This is the goal of the principal workforce goal for the board for the state of Arizona. It's obviously a multi-year goal, as you just heard President Crow walk through the timetable. And in the case of NAU's proposal, it will even take a little longer. They're going to go into spaces that are going to take just a lot longer to do. So, a long-term, multi-year, multi-board, by the time we get the first graduate, every member of this board will be gone and replaced by a new regent. So this requires really serious, board commitment. Then our job is to be advocates for it, build coalitions around it, work with the Arizona Medical Association, work with the physicians, work with the providers, work with everyone who is part of this conversation. And then third is hopefully creating the political will to create the investment necessary to do this. This will be, I don't think we've totaled it all up, but, hundreds of millions of dollars over many, many years. And yet I can't think really that there's anything that we could be doing that's more important that touches the quality of Arizonans' lives. I mean, if you can't get good health care, boy, what else is there? It is just so principal in families' lives and wellness. So it's a long-term stick-to-itness, and it's going to require a lot of participation of a lot of our partners at the state. And as Michael can describe in detail, where ASU excels is a wide variety of very innovative relationships and partnerships across a variety of different platforms to bring private capital and private talent to bear on the task.
Yeah, Gary, what I'll add to what Fred was just saying is so our goal is, if our goal is just to produce more doctors only, that's relatively simple. You build a traditional medical school, you attract students to it, you start producing them, and we certainly will be doing that also. But what our goal here is actually to impact the healthcare outcomes of Arizonans on a large scale. So we rank in the bottom third of states in terms of healthcare outcomes. We have some populations that do particularly well and other populations that do acutely poorly. And so why we have this disparity, we think that the way to attack this disparity is technology. And technology married to the healthcare provider in ways that we're seeing now and glimpsing now, but not able to fully take advantage of. There's all kinds of things going on, telemedicine, and all the great healthcare providers here in Arizona have all kinds of assets. But what we need more innovation in the system. People talk about the cost. The reason that health insurance is so problematic is it's so expensive. Healthcare is just so overwhelmingly expensive. It's all face-to-face, person-to-person. Come into the office, wait in the waiting room, wait to be called. Well, what if there's other ways to do all of this, which are actually I say this in all seriousness, which could actually end up being better, and with better outcomes and lower costs. And so we're also focused on how do we get those two objectives: better outcomes, lower costs. Let's look at school attainment, educational attainment. One of the main factors impacting kids not doing well in school is students that have asthma, and ways we're not helping students in their homes to manage asthma enabling environments, which then are keeping the kid out of school, lowering their chance of success. So we think there's other ways to build tools and systems and devices to lower healthcare costs, produce better healthcare outcomes, produce better life outcomes, but also produce more high school graduates. We still have 20% plus of the kids that start high school don't finish. And then the outcome for a person with only a less than a high school education right now is their opportunities, with some exceptions of rare individuals, are very limited. How do we impact all of that? And that might sound like a lot that we're taking on. And the answer is yes, it is a lot. And that's what we're taking on.
Now, you gave a presentation to a legislative committee a couple of weeks ago, and one of the things that you talked about was, this being a hub linked to many partners.
Yeah.
Can you talk about that?
Yeah, so the way that we work, like for instance, ASU just announced a partnership with OpenAI, which is one of the largest artificial intelligence firms that is advancing. We have a massive new partnership with Google and their learning part of their company. We have funded projects with YouTube. Let's just take YouTube as an example. So YouTube has billions and billions and billions of videos there, and not all of them are stupid pet tricks or fail videos. There's knowledge, wisdom, instruction, ways of doing things, ways of solving things, ways that people have solved all kinds of things. How do you organize all of that so that when you ask a medical question, we have filtered YouTube down to, and here are the best 5 instructional assets possible to help you to manage long-term rheumatoid arthritis in your family in a visual way. We're working with all of these partners, and that's just on the information technology side, and we're working with them already. Then in partners in medical care, healthcare, another thing that we're doing in our design is that we're going to be working with everyone. We're going to be working with physicians everywhere. We're going to be working with all of the nurses, not just the nurses that we produce. New ways to enhance learning. We're working with learning technology companies. We have a whole new way that we teach biology. If we could get people to understand biology just a little bit better, they would make choices that would enhance their children's success and their family's success. Things have gotten so technical, we can't understand them. So, what is a messenger-based ribonucleic acid virus? And how do you use a messenger-based ribonucleic acid vaccine to attack it? Like only one person in 10,000 knows what that means. Yet that's the way people are talking. And so how do we help people to understand things so that they can make better choices? Whatever choice you want to make, that's fine, but at least be informed when you make your choice. So we're partnering across all of those things.
Yeah, does that go to health literacy? That's another thing you
Right. Yeah, so what we're going to be, we own KAET television. We broadcast that digitally over the airs that you can pick up on cable TV, but we also have 3 or 4 completely digital channels. We're going to be devoting one of those channels when we get this thing designed to only health literacy, health outcomes, helping people to find the right information, helping people to make the decision that's best for their individual family. So we're going to be working on that, as well as using a group at ASU that we call the Learning Enterprise. The Learning Enterprise has hundreds of thousands of learners that are registered for courses and millions of learners that are not registered already, where we're going to have all kinds of things focused on helping families to make and individuals to make the right choices by having access to as much information as possible. Not just information that we're putting together, but information that's coming from everywhere, synthesized for you individually. And so that's what we're working on as a part of this ASU Health activity also.
All right. And so the third prong of your initiative is to build a public health technology school.
Yeah.
And I understand that came from, what happened with the pandemic.
Yeah. So the pandemic, it's unbelievable the things we got wrong, the things we got right, the arguing, the debating, the what to do, how to decide, how to make things happen. And it turns out that there were lots of things that we could have done if we'd been more technologically capable. So one of the things that we did at ASU, we were operational with hybrid classes for all but 7 weeks of the entire pandemic. We kept our dormitories open. We built technologies that allow you to know in the wastewater stream coming out of residence halls whether or not there's any active virus or other kinds of bugs that might be in the wastewater stream. So we knew what was going on. And so what we did is we saw an idea out there being developed by a woman by the name of Susan Blumenthal, who used to be the Assistant Surgeon General of the United States, was that we needed a new kind of public health school, a public health technology school, one that would focus on tools and devices that would help you to understand what to do and what the real risks were, and how to monitor what was going on. Look at what was going on inside retirement homes and nursing facilities where you had high death rates, and it's like it was 1850. We didn't know what was going on. Where was the virus? How was it going? And so how could we have better technologies in places that are particularly vulnerable, and then not apply the same strict regimens perhaps that we applied to everyone, because we didn't really know what was going on. So in a sense, we over-calibrated in some places, under-calibrated in others. And what we needed and what we need more of is a whole new technologically enhanced way to understand what's happening. So this new public health technology school, and we can get out to anybody if they want it. We had a whole group come together of experts from all over the country, all over the world. They came together and we've designed this school. So we're further along on the launching of that school. We're searching for a dean or a director for that school now, and looking forward to getting that thing up and running. And what you can imagine is, more tools. So how do you know when there's a health issue at a school? How do you know when there's a health issue in a nursing home? Do you wait until the patient is manifestly sick and has already infected 15 other people, and then 50 other people, and then 400 other people? Or is there something that you can do that is quicker and better and so forth? And the answer is yes. We just need to figure out how to do it at the lowest possible cost. And that's what this public health technology school is going to do.
Now, are there any examples of, the medical engineering or the public health technology school,
Yeah, there's
anywhere else in the nation?
Yeah, there's two examples of medical engineering schools. One is at the University of Illinois at Urbana, and it's a very sophisticated prototype. And then a second one has been built. There's only two of these. One is at Texas A&M in a new medical school campus that they have in Houston. And then in public health technology schools, the answer is no, but there are lots of centers inside public health schools, in a sense, struggling for more impact and more connection and more precision. And so we do have some prototypes to look at in the US and then around the world. There are examples everywhere. I was in Australia a couple months ago in Sydney at the University of New South Wales, and I went into a lab, a room filled with nurses, and all of the nurses and the others that were in the space, they were managing many patients with monitors. They were wearing wearable devices, Fitbits and things like that, and they were monitoring all of their daily activities in ways in which they had predictive models of when an issue was occurring relative to some health issue that they had. It was unbelievable. They were helping these people with enhancing their life outcomes. Everybody selected this. Everybody wanted to do this. And so it was a great example. And so it was very informative to me anyway, in this particular lab, in this particular hospital, at this particular university, with the number of people whose lives could be enhanced by just a few nurses monitoring their data on a daily basis with predictive models relative to them, helping them to have better chances of healthy life extension.
So I've got one question from the audience. So what will ASU Health do with prevention of disease and health promotion rather than the diagnosis and treatment of diseases?
Yeah, well, the health literacy program that we have, the other programs that we have in our College of Health Solutions, we have one of the largest nutrition programs in the country. Today, we just have a chance to talk about, the new things that we're doing as opposed to the things that we've been doing that we'll be expanding. So what we'll be focusing on relative to prevention. So prevention is, all kinds of things, lifestyle choices, nutrition choices, all of that, and then educating people about that. But then it's also understanding individuality, understanding personally what's my body is in a weird body, and it's different than anybody else's body. That is, it has this positive and this negative and this positive and things I inherited from my parents, both of whom died of cancer. So the other thing in terms of prevention is moving everything into personalization, using computational tools, your genetic background, your particular life history, and then using that to say, okay, well, now, Michael, here's what you need to do to stay on a healthy track for you to prevent these kinds of diseases, which are manifesting in your family background, or in your, if you were exposed to something as a child, all kinds of things. And so that's the best way to move to prevention, is personalized healthcare analysis.
And Gary, if I could jump in here, it's important. We think about this, it's such a misnomer when we talk about a healthcare system. Because what we really do is we've built a disease management system. I mean, this is a system that responds to people who are facing ailment, as opposed to, front-loading prevention and education and better choices, et cetera. And so a lot of what President Crow is talking about is focused on how do you keep people out of the disease management system.
Yes.
With tools. But it's not just at ASU, and I want to get back to my role regarding the system. And I see that one of the viewers referred to Andy Weil's center at U of A, which I toured yesterday. This notion of wellness is embedded in all of our conversations at all three universities. MAU will have a very, very strong enhancement of the behavioral health strategies, because behavioral health gets so often neglected, and yet is such a critical component, not just of the healthcare system, there I use that phrase, but also of the wellness strategy that is required in order to keep the costs down and keep people healthy. So this broader prevention notion is absolutely an imperative to our society and system, and it is embedded in all of our thinking.
So here's an example. So years ago, when 23andMe came out, I sent in my spit for $99 and got back, my family background and, the fact that I was heavily influenced by Neanderthal DNA and so forth and so on. But then since then, in the years since then, they've been taking that same DNA sample that they have of me, and now I know, I sort of knew this already, but now I have genetic evidence that I have a high proclivity for a propensity to type 2 diabetes. Like if I didn't do anything in my life, it'd be like 40% probability genetically. Oh, well, that's a boatload of information for me, because I can now take that boatload of information, I have it early, and then I can do this and this and this and this. And you can even see how this to lower that probability down to 4 or 5%, which is sort of what the normal percentage is for lots of people. And so the key there is I'm a lot more expensive patient as a person in my 60s with diabetes, or in my 40s with diabetes, than I am as a person who prevented that diabetes from coming along. And so plus my life will be longer, less of a chance of blindness and other kinds of issues, all kinds of negative things that come about from that. What we need is a system where everybody has that information if they want to have it, and then they're making decisions that they're being informed about relative to positive, lower cost health outcomes, rather than just random outcomes or what I would call ignorant outcomes. You're like, I didn't know, but now you do know. Now you can know, and it's not very expensive, and we can make all this work.
And how is it going to keep the costs down? Because I'm listening and I'm thinking, computation, engineering, all
Yeah.
all these things that are going into this. It sounds expensive.
And it's the opposite. I mean, so you got to look at the way that all these computational tools have changed everything. So let's just take what it costs to deliver a lumen of light in our existing electrical system with advanced computation and engineering is literally many hundreds of thousands times less expensive than it used to be to deliver whale oil based light. What I'm telling you is that technology lowers all costs. The two industries in which technology has been beaten away to lower costs are education and healthcare. ASU has, really taken a leap of faith. The board has really allowed us to do this in terms of education. And what we've seen is that these technologies lower our costs, enhance our efficiencies, enhance our outcomes. We're going to apply the exact same logic to the people that we're producing and the ideas that we're producing in this healthcare space. And so all costs will be lowered, particularly when we get down to personalized, early, individualized medicine. Absolutely.
Okay. And so how is this going to, how is ASU Health going to benefit the state economically?
Well, Fred mentioned that part of the logic here is the notion of, to do all this, you need new businesses, new enterprises, new software coders, new tools, new devices, new systems. So our hope is, and I think the Regent's hope is also, that we help facilitate accelerated outcomes relative to healthcare technology. So, for instance, we're partnering with the Mayo Clinic in the Discovery Oasis in North Phoenix, which is a couple hundred acres that's being developed to attract the whole new elements of digital medicine, advanced medicine, cancer prevention, every kind of tool imaginable. So it turns out that healthcare and healthcare technologies are also businesses. And that's what I know that's part of what the Regents were looking for from us.
And
look, Arizona's at a inflection point in this life sciences debate. 20, 30 years ago, Boston and La Jolla and some of these other places that sort of really drove into this space. And we now recognize across the country that improving health outcomes, health technology, these are ripe for growth. And we want to be a part of that economy. And if you look at our assets, the president has mentioned some of them, Mayo, Banner's got a lot of things. In brain health, we are among the nation's leaders. We've got the PBC, which is now sort of an accelerant in downtown Phoenix for collaboration of private and public sector in all three universities. You've got CPATH in Tucson, which is accelerating pharmaceutical trials. You've got TGen. So we've got this critical mass. And one of the topics I think we'll probably touch on is the placement of the ASU Medical School, which the president will address. But recognize that this sort of life sciences ecosystem in downtown Phoenix has the potential to become a AAA player in this new space. And we ought to be. I mean, that's one of our obligations is to help both educate our students, create workforce, and become the accelerant for these kinds of new technologies, capital formation, and new business startups.
Well, I don't know that people. I mean, so healthcare is a multi-trillion-dollar industry just in the United States. Multi-trillion-dollar industry. It's a substantial part of the overall economy, and in all of that, not just new drugs, and there's fantastic new drugs in metabolic management and weight control and all kinds of things that are happening and everything breaking through, but then there's new home-based health systems, new wearable devices, wearable technologies, new ways to enhance your body systems that begin breaking down. The whole technology is associated with knee and hip replacements and all the things that are moving forward with other kinds of repairs that you can get to your systems. Lasers that are used in LASIK surgery. So who built those lasers? I mean, the laser was only invented in an academic institution in 1960. And now it's used in all kinds of things. Well, there are hundreds of companies and tens of thousands of people, hundreds of thousands of people working in these industries building all of this. And Arizona and Greater Phoenix have an opportunity to become even more of one. It already is one of these places attracting all of this, but even more so. Tucson is very big in the biomedical space. Phoenix is very big in accelerating in the biomedical space. And so the key here and our design of ASU Health is to be what we call a hub spoke model, where we ASU are a hub and we're connected to research organizations, technology development organizations, innovation clusters, healthcare organizations, hospitals, and so forth. And as Fred mentioned, we're going to be building in a sense, the ASU Health Innovation Center, which will be the headquarters for the medical engineering school and other things that we're doing in downtown Phoenix as a part of this hub spoke model. And we'll ultimately be selecting a clinical partner to work with our medical school. And then we'll be connecting with that organization very intensely while we're still working with Phoenix Children's Hospital and the county hospital and everybody else to advance healthcare outcomes.
And one of our viewers asked, if ASU Mayo, if the ASU Mayo partnership's part of this effort.
Yes, so ASU Mayo partnership. So we have a fabulous facility on the Phoenix campus of the Mayo Clinic, Arizona. It's the manifestation of the ASU Mayo Healthcare Alliance. That will continue. We're working with their medical school and their staff and their researchers while we're also working. We have a research center at Banner. We have new activities that we're working with relative to Honor Health. We're working with City of Hope in the TGen Center through research, and the City of Hope Cancer Treatment Center here in the West Valley. We're working. If anything, all of this just expands, and the technologies allow us to work together as a virtual medical center. Over in Texas, they have this massive thing in Houston called the Texas Medical Center, where they've packed everybody together. We have sort of a core for that called the Phoenix Biosciences Core in downtown Phoenix. We're a part of that. U of A is a part of that. NAU is a part of that. And then in our case, we're then connecting out to everyone in different ways. And so Mayo, yes, they're still our significant partner.
So, as somebody who covers politics and whenever people come forward with great ideas, my first question is always, how are you going to pay for this? I think there's 153 million budgeted for fiscal year 2025, and I think ABOR is contributing to that as well.
A little bit, conflating a couple of statistics. So our budget ask this year of the state was 153 million, of which the executive budget request is 46. And then obviously, we'll go into the appropriations process, which I think starts this week, if I'm not mistaken. I think the president's
tomorrow,
yeah. The governor has found us $26 million to help sort of get a lot of this planning going to date. And then the board, through its TRIP funding, has also helped fund the startup. But to take this to scale, as I mentioned earlier, that we're talking about hundreds of millions of dollars, and you can't get there without state help. Obviously, we will be highly aggressive and innovative in finding every possible way of bringing third-party support to the task. But this will be a multi-year funding ask that, there'll be many legislative term limits will have come and gone, and we will still be asking to grow these facilities in order to meet the healthcare needs of the state.
So what I'll say, Gary, is that the ASU model is the model that we sometimes refer to as a public enterprise. It means we're owned by the public, we serve the public, we're governed by the public's people. I'm appointed by a public board. Fred is the chair of that board. And then below that, the university operates as an enterprise. We seek resources from partnerships, and we seek resources in the market by competing. We seek resources from every possible way. We leverage every asset that we have, our real estate assets, our technology assets, everything. And so the ASU Health program will be advancing in this public enterprise model. It's not a government school. We're not asking the government to fund the school. We're asking the people of Arizona to make a startup investment in the school and to help people to attend the school. And so, we wish that we could be where Texas is, where Texas is investing over $40,000 to every student going to a Texas medical school in a Texas public university, of which there's many, many medical schools. We don't have anything like that in Arizona. So what we've been trying to say politically is to the state and to others, we'll run the university. You can help us when we have special projects like building a new medical school, and then please help people to attend, people from Arizona. Please help people from Arizona to attend the university in a way where they can afford it. And so that's really what this model is the same. So we're building a model in which, we're not in of all places in Texas, they're spending, literally hundreds of millions of dollars, billions of dollars, building new medical schools, building new research labs, making these things happen all across Texas. We're not asking for that. We're asking for startup investments, and we're asking for help with students. That's really where we are.
But in addition to the Texas model, look, the competition is on. California, which has some more organic strengths because they started earlier in this. I mean, they recently, UCLA alone, I think Michael correct me, I think it was $1 billion commitment.
Well, yeah, $1 billion for one research center.
For one research center
in medicine and then in addition to that, they just spent $700 million to buy one piece of property to build this advanced research institute in immunology. And they believe that with this immunology thing that they're building, they're going to be able to, in a sense, corner the intellectual and technological and economic market in advanced immunology, which is unbelievably important. Your flu shots, your diabetes shots, all kinds of things.
So the point of that is, as the president said, we're not relying on the old model of just going to the state and saying, pay for this for us. We will find every possible way of spreading these costs across partners and other funding strategies. But we will need long-term state support as our partner. And I do think that the case is quite compelling. I mean, I can't think of anything other than education and the quality of people's health that matter more to Arizona families. And we can't get to where we need to be to serve those families unless we provide more workforce.
Yeah, what's interesting, I'll just say that, the politics in Florida and the politics in Texas are both, solid conservative politics. And in both places, they've been making massive investments, public investments, in new medical schools, new research institutes, new research labs related to medicine. In Texas, they had a $3 billion initiative on nothing but cancer science. How does Texas become the center for cancer science? Because there's two things you get out of that. You get cancer solutions, and you get the companies fighting cancer by developing new tools and so forth and so on. A new medical school at UT Austin. There's the MD Anderson Cancer Center, which is a part of the University of Texas. It has more research activity in that one center than all of the universities in Arizona combined. And so what we haven't done in Arizona yet is we're not thinking big enough. We're thinking a little bit too small, in my view. And what we're trying to do with this new ASU Health idea is build a boundless model, enhanceable through technology, that can accelerate to the scale that Arizona needs. That's really a way to sort of put this.
All right. And I want to throw another question at you from the audience. So how will ASU Health Innovations engage stakeholders and affect insurance and pharmacy benefit manager payer systems where reimbursement standardized rather than personalized medical care? If you
Well, that's
Will
a
you
very
touch on that?
astute, that's, I understand that. That's a very astute question, which is that we have the system that we have now, which is
Right.
wasteful, expensive, problematic, bureaucratically complex, where you have multiple levels of profit seekers along the way in the model. You've got you've got the insurance brokers, you've got the pharmaceutical middlemen, you've got all these things going on, and I'm sorry to tell all of them, we're here to disrupt that. And so to disrupt that, so that what we're interested in is the person, the family, the child, the parent, the elderly citizen. What we're interested in, how do we deliver to them the information they need, the insights that they need, the tools that they need, the systems and the devices that they need, so that they can take better care of themselves. Right? We're about the empowerment of the individual. The old system is really built around, in my view, lots and lots of profit seekers who need to be disrupted.
Gary, if I could add one statistic that a CEO of one of our major healthcare systems gave me. He said half the cost of all of our healthcare is outside the relationship of a willing provider and a needy consumer. Half of it is in every other aspect that is not connected with that engagement. That's what we're trying to get at.
All right. So is the school going to be affordable for students?
Well, part of our public mission is to do everything that we can to do that, and we've certainly figured out how to do that relative to ASU itself for people from Arizona, and even for people from other states and people from other countries that come here. So ASU has one of the most affordable pathways to success. Now, medical education is much more expensive, just like nursing education is very expensive. So the way to make things affordable is to use technology to keep your costs low, but also to find scholarships and ways to invest in these future doctors. And Arizona needs to be a place where they're going to invest in the people themselves. And so we are going to be making the case for investment in doctor and nurse production. There's all these people running around, for instance, about nurses, and they're saying, well, we're not producing enough nurses. Well, Arizona, unlike Florida, unlike Texas, unlike Colorado, unlike other states, doesn't invest in nursing production at the level that they might. And so that is helping people to go to nursing school and to afford it. So right now, here's our problem relative to nurses. So it costs $30,000 a year to produce a nurse, and an in-state nursing student will pay $12,000 for that education. We will scholarship half of that in general, so $6,000 of net revenue against a $30,000 cost. And so the reason I'm saying this is that in most states that want more nurses, they're investing in the nursing pipeline. So we do need investment in human capital development, but in any event, we will make it work and keep the costs as low as possible.
And when it comes to the expanding or trying to triple the number of nurses, you also want to expand the research from there, right?
Yes, absolutely. So nursing research, how do you make things more effective? I mean, nurses are, one of my sisters is a nurse, social worker working in the area of genetic-based oncology. And my other sister works in healthcare herself. And so what we need in frontline, on the ground, person to person nursing healthcare is more research, like these nurses I saw in Australia, who are managing and in a measurable way enhancing the lives of thousands of people by just working with them on the data of their day-to-day lives. So that's nursing research on how to have better patient to healthcare system interfaces. We need all of that.
And I've got one more question from the audience. This new model is innovative and much needed. How can those currently involved in medical education look into potential opportunities to join the team? Has the blueprint of courses and those directors been chosen?
So we have what we call the landing team, led by Dr. Shireen Gabriel, who was the president of Rush Medical University and the former dean of the Rutgers Medical School and the former dean of the Mayo Medical School. And she's assembled what I think of, like in the Marine Corps sense, the landing team. And then she and her team are now out looking for all the other talent that we need to build each of the individual schools and to expand our activities. And then we're going to be hiring new people into all of that. Then we're going to be connecting with healthcare workers and healthcare professionals throughout Arizona in new ways, connecting to these new initiatives that we have. So there's going to be lots of opportunities to stay connected. And so just stay tuned to where we're going and where we're headed. There's going to be lots of opportunities to stay connected.
All right. Well, we're coming up with about 4 minutes left. You gentlemen want to take us out with some final comments?
Go ahead, Fred.
Yeah, look, I would just simply say this is it's a deflection point. I mean, this is an opportunity for us to really leapfrog ahead in the direction of the workforce that Arizona needs, as well as driving life sciences. There are barriers. Funding is one, and the other is residencies, which we didn't talk about. But residencies is a bottleneck for the creation of physicians, and one that we're going to have to tackle. And everybody that's involved in the healthcare business understands that and is part of that conversation. But we will tackle those and really sort of unveil this very, very exciting future for the universities and for the state of Arizona.
So what I'll say, Gary, is that of the 30 richest countries, they're called the OECD countries, the Organization for Economic Cooperation and Development, OECD. The U.S. is, unbelievably wealthy and unbelievably successful, but we have the most expensive healthcare system per person by 2 times, and we don't rank in the top 25 of countries in terms of medical outcomes. So we have a serious, serious problem. This is something I've written on myself, and we have a design problem. Our system is not effective at the high end scale, and it's unbelievably costly. If all we think that we need to do is produce more doctors or just more nurses or just more people, and it's somehow going to get better, that's not going to happen. What we need is a completely new set of approaches. And so what we intend to do is to, drop our rock in the pond in a highly disruptive way and start affecting outcomes with everyone that we interact with, other healthcare organizations, the healthcare organization that we ultimately partner with the medical school, the individuals that we're working with, the schools that we work with, the companies that we work with. That's what we're after, because the system that we have right now is not effective. We have declining lifespans in the United States right now. For people with a high school education or less, lifespans are dramatically decreasing. I mean, dramatically, like never seen before in our history. So obviously, when you see something like that going on, if you just sit back and say, I guess all we need is a few more people out there on the football field, I'm like, no, football's not really the game anymore. It's a new game. And so what we're trying to do is to launch that new game.
And I think this will keep you in the top of the rankings for innovation. So,
well, especially if we're successful.
We're counting on that.
Yeah.
So, all right. Well, that wraps up our discussion today on ASU Health. Stay tuned, people, because you're going to hear a lot more about this over the years as they build it out, and it becomes applicable. So I want to thank our guest, Michael Crow, President Michael Crow, and Regent Fred Duvall for taking an hour with us, and thank the audience for joining us as well. And I hope everybody has a great day. Thank you.
Thank you. All right. Bye-bye.